Ladies and gentlemen, welcome back to another episode of the CCFP 105 Topics podcast. I am Braden Paul, PGY2 Family Medicine from Victoria, BC, joined as always by the legend himself, Caleb Dusdall.
Braden killing it in Victoria still. This episode was kindly written by Nova Zhao. He's a PGY2. Well, he was a PGY2 at the time of writing, actually, and he's probably done off in practice making lives better. So thank you, Nova, so much. Again, he just reached out via the email and made it happen. He kindly also brought on board an expert reviewer, Dr. Tania Wong. She's a pediatrician and assistant professor in the Department of Community Paediatrics at Dalhousie University. Thank you guys so much. It's great to see people coming out from the East Coast as well to support the cause. Objective 1. When evaluating children, generate a differential diagnosis that accounts for common medical problems which may present differently in children.
So, today, as the objective suggests, children often present differently than adults when it comes to medical issues, so it's really important to keep a broad differential, and if their symptoms are non-specific, so specifically depression. Depression can look different in kids than adults. While they can present with the typical M-SIGI-CAPS symptoms, the things we all know, low mood, difficulty concentrating, etc., they can also have some unique symptoms of their own, which include things like
a change in their school attendance or performance,
changing in their extracurricular activities, such as missing sports practices,
a change in their friend groups,
and somatic complaints as well, so things like belly aches and headaches, since children often have a harder time expressing their emotions verbally.
Many of these symptoms should reveal themselves if you regularly do your HEADS, HEADSS interview, which we'll come to in the next objective, with the kids and teens in your practice.
But you can also use the PHQ-A, which is a version of the PHQ-9 depression screening tool that has been modified specifically for children between 11 and 17 years old.
Infections in younger kids and infants may present with non-specific symptoms such as fever, irritability, lethargy, and poor feeding. For example, UTIs.
Urinary tract infections are relatively common in children. The symptoms here vary with age, so newborns with UTI may present with jaundice, sepsis, failure to thrive, vomiting, or fever, whereas infants and young children may present with fever, strong-smelling urine, not sure who's doing that, but in any case, strong-smelling urine, hematuria, abdominal or flank pain, and new onset urinary incontinence.
You don't smell and taste the urine?
I've stopped doing that. Apparently it's uncouth.
What are we learning these days? School-aged kids can start to present with more adult-like symptoms like your usual dysuria, frequency, and urgency.
Studies have actually shown that infants with a fever greater than 39 for greater than 48 hours without another source of infection on exam are fairly likely to have a UTI.
There's actually a cool website, and this wasn't peer-reviewed, so don't put too much credence on this, but I use it often. It's the Pittsburgh UTI score, and I'll see if I can add a link for it. It's nice in a pinch when you're like, oh God, what do I do with this kid, and do they have a UTI?
Nice. Love me a good risk calc.
And they can also present somewhat differently with pneumonia.
The symptoms of pneumonia may be non-specific, as you might imagine, particularly in infants and younger children.
Common symptoms to watch out for include acute onset of fever, cough, difficulty breathing, poor feeding or vomiting, and lack of interest in normal activities. You also might see chest or abdominal pain.
The most important feature on physical exam, though, is actually tachypnea, and it's fairly helpful for ruling out pneumonia. Studies have shown that in febrile children, the absence of tachypnea has a fairly high negative predictive value, 97.4% for pneumonia.
Negative predictive value in kids is my favorite.
Gotta love it.
Since symptoms often overlap with viral infections, ideally the diagnosis of pneumonia should be supported by a chest x-ray.
So what about appendicitis? In a child presenting with acute abdominal pain, as we all know, you really always have to include appendicitis on your differential.
Appendicitis tends to peak in adolescence, but it can occur in all kids, so don't discount it in the younger ones.
You can use a clinical prediction risk score such as the Pediatric Appendicitis Score, the PAS, which has a positive likelihood ratio of 2.4 and a negative likelihood ratio of 0.27. The PAS takes into account things like fever, mid-abdominal pain that migrates to the right lower quadrant, nausea, anorexia, elevated left shift in the white count, cough, percussion, and hopping causing pain in the right lower quadrant. There are some other clinical risk score tools out there, but for the purpose of this podcast and our exam, the PAS is the one to know.
Objectives 2 and 3. As children, especially adolescents, generally present infrequently for medical care, take advantage of visits to talk about unverbalized problems, social well-being, modifiable risk factors, and risk behaviors.
The best tool here is everyone's favorite heads or heads interview. So that includes a few different components, starting with, of course, home and environment. So for this, you can ask things like, where do you live? Who lives with you there? How's life at wherever you live?
E is for education and employment. You can ask, are you in school? What are you good at in school? How are your grades in school? And you can also add, regarding home and school, do you feel like they're safe places for you? Do you ever feel threatened or bullied here?
Next, E is eating. So you can ask them, what do you like to eat? Have you ever dieted? Does your weight or body shape cause you stress? Our expert editor, Dr. Wong, actually suggests wording it more like, do you eat all the food groups, or do you restrict or omit certain foods? This way may be less threatening for certain children, and it may actually cause them to be more likely to reveal their eating patterns to you.
That's a great tip. A is activities. What do you do for fun? What do you do with your friends?
D is for drugs. So you can say something like, many young people experiment with drugs, cigarettes, and alcohol. Have you or your friends ever tried them?
I like that question too.
It's a great question.
Sexuality is the first S. Have you ever been in a romantic or sexual relationship? Are you interested in boys, in girls, both, neither? Are you sexually active? Do you use any form of protection if you are? Dr. Wong suggests that we also ask about gender. It can be a cause of major distress for kids, especially those going through puberty. You can ask something like, what's your preferred pronoun? Is it he, him, she, her, or something else?
Moving on to the first of the 3 S's for suicide and depression. So for this, you're going to ask, starting with mood. How has your mood been lately? Sad, happy, stressed? And then we move on to, have you ever had thoughts of harming yourself or killing yourself or others? These can obviously be very challenging things to talk about, but there is no evidence to suggest that bringing these topics up to young children actually cause them to be more likely to act on any impulses that they may have.
The next of many S's is safety. Have you ever been seriously injured? Do you wear a seatbelt in the car? Do you wear a helmet while you're biking? Have you experienced any violence at home, at school, or in your neighborhood?
And the final S is social media. Really, this is just asking them if they actually have social media, which most children above a certain age probably will. And then from there, we're branching off to bullying. As we all know, bullying online can certainly be an issue for children nowadays, and so it's important to ask about that.
Man, sign of the times having that extra S on.
Mm-hmm.
Well, you might not have time to discuss all these topics during one visit, 9 minutes or whatever they're providing us these days. It's possible to spread them out a bit, or book them for a bit of a longer visit if you expect that this is something you want to get into.
You can consider using a tool like the Grieg Health Record, which is essentially like the Rourke exam, except for older kids and teens.
Objective 4. In adolescence, ensure the confidentiality of the visit and, when appropriate, encourage open discussion with their caregivers about specific problems.
So we all know that teenagers like to keep to themselves. We've all been there. Some of us are still there, in fact. So it can help if they know that anything that they tell you will be kept confidential, except when required by law.
You can say something like, during this visit, I'll ask you some very personal questions because I want to help you. I promise that whatever you say will be kept in private between us. The only reason I would disclose it to someone else is if I need to by law. For example, someone's life being in danger.
It may be helpful to start off the visit with this statement, particularly if you plan on discussing some of the more sensitive stuff later on.
If they're hesitant to speak with their parents present, you can encourage them to open up to their parents. But tread lightly here and let your patient decide when it's time for them to share with their caregiver. Objective 5. In assessing and treating children, use age-appropriate language. It's a big one.
It is indeed a big one, and this one's fairly self-explanatory, thankfully. Essentially what it means is just don't use advanced language or medical jargon around children. And in fact, for all patients, that's really something that holds true. But get down to their level if you really want to have the most effective patient-doctor relationship with those kiddos.
Objective 6. In assessing and treating children, obtain and share information with them directly.
This is fairly similar to Objective 5 in the sense that we really want to be directing the conversation that we use to the children. And so if their parents are present, you still really do want to make sure that you're focusing your attention on the child or the adolescent themselves.
Parents and family members should not be present for the head's interview because it can limit how much sensitive information that they can share. It can also put the child at risk.
It is, though, important in that light to ask if parents have any concerns before they leave the room, because obviously they can still be a very important source of information.
Objective 7. When investigation is appropriate, do not limit it because it might be unpleasant for those involved.
Fairly self-explanatory. Sometimes you need to do exam maneuvers or investigations that may be unpleasant for the child or the parent or even yourself. I'm sure everyone listening to this has had the dreaded issue of having to look into a toddler's ears. Meanwhile, they're screaming and then internally you're screaming as well. But you have to get it done. And really, if you're suspecting otitis media or externa, you have to look in their ears.
Similarly, if you suspect diabetes, you have to check their blood glucose.
Limiting your investigations due to discomfort on anyone's part can lead to misdiagnosis and potentially harm to the patient. And so just be mindful of that. Of course, nobody wants to injure or hurt children, but sometimes the investigations that we do can be uncomfortable and we just have to put up with them.
This sounds stupid, honestly, but I constantly feel this. Like I'll be in the emerge and you have a febrile child and you're like, oh, I don't want to get a CRP and a white blood cell count because I'm putting a hole in this kid and they're going to hate us and hate the healthcare system. But man, you feel so much better and the parents feel so much better when you can rule something out or if you catch something. The last thing you want is to miss it and find out 2 weeks later they've got this awful hearing issue or something because you didn't look in their ears like a silly goose. Don't be a silly goose.
Don't be a silly goose. That's the lesson for today.
So this has been an inexplicably named In Children episode. Thanks so much to Braden for coming to co-host. Thank you, Dr. Nova Zhao, for writing this and taking on the lead with this episode, and also bringing on board Dr. Tania Wong for expert review. It means a lot. You guys are incredible. Lovely to see contributors from coast to coast now. We do have a bit of a page put up if you want to have a look. Under team, there's a contributors page, which just has a map of everyone, so you can see it in map form that this is it's a national effort to make this what it is so far, and we couldn't have done it otherwise. All right, that's it. Come help us. The usual spiel, and goodbye.
Take care, everyone.